Hello, hello, ladies and gentlemen. This is a webinar put on by OcPhys Consulting. This is the third one for the year. I have the pleasure to present. It's on the road to recovery, focusing on return to work strategies. And the actual title is How the Occupational Environmental Physician, the OEP, may optimise this process. I'd like to welcome you all. So who am I? My name is Chris Cunneen. I'm an occupational and environmental physician. As you can see, I've been around for a few decades. I've had almost 3 decades working in the occupational and environmental space. For my sins, I've worked in the hospitals in multiple roles, particularly orthopaedic neurosurgery and ED roles. Been a visiting medical officer, been a GP as well before that. And as you can see, I've worked in multiple jurisdictions. They're the ones that have worked in recently, and I've restricted a few of them. And I've also had the privilege of being an advisor to government, both at state, federal and local level, and had decades of experience with the Australian Army and have a life outside. So it can't be unidimensional. So moving right along, I'd like to acknowledge the traditional custodians of the land and waterways on which we live, work and play, and pay our respects to our elders past, present and emerging. And also, as I said before, I'd like to welcome everybody. We've got a very broad case mix of attendees today, multiple stakeholders in various areas. It's not just Queensland, we're very much heavily focused on Queensland. We've got people from across the Australian mainland from various states and territories, and even a few from across the ditch. So I'd like to welcome you all. Kia ora. And as you can see, we cover quite a few of the important stakeholders, and that's good, because hopefully this will be relevant for all of you. It's not just a medical presentation by a doc. I'd like to start with the beginnings of a case study. This is a real case study. It's actually one of the first ones I did as a file review when I hung out my shingle as an occupational and environmental physician, moving into independent private practice. This case study I picked because it really reflects the best and worst practice of return to work strategy and how we can all learn and do things better. So we've got Jake. He's 23-year-old, otherwise healthy male. He'd worked as a kitchen hand in a hotel for 3 years, been a solid worker without any concerns. His work colleagues often played pranks on each other, and he was the butt of one of them one day. And as you'll see, this prank went horribly wrong, and he basically lost 2 years of his life. So it sounds terrible. Medically, it's probably not as bad as it could have been, but certainly it illustrates the worst practice of return to work, as well as medical practitioners not actually assessing the person, rather just assessing the complaints and an organ system. On another happy note, I'd like to flag that the health benefits of good work, an initiative put out by the Australasian Faculty of Occupational and Environmental Medicine, OFOM, of which I'm a fellow, under the banner of the Royal Australasian College of Physicians. So they are medical specialists. Over 10 years ago, I think it was 2009, it started, where they decided as a group to raise people's awareness across industry and multiple stakeholders that basically good work has health benefits that transcend just turning up for work and performing a job. And basically did a little literature search and conducted ongoing research to confirm that chronic absence from work, claims that become long tails, are associated with work disability, may lead to unemployment. And as we all know, this has a very unfortunate and negative impact upon not just the employee, but usually their family and certainly their health and well-being. There's a reference there. Should say there's a list of references at the end. So that's sort of been around for over a decade. I still run into stakeholders, unfortunately doctors, considerable number of doctors don't understand and not aware, and there's a challenge for all of us there. There's a few learning outcomes for today. None of them are terribly startling. One is just to give you a refresher on current return to work statistics. For those who are in the state or across the ditch, I apologise that this will be very Queensland focused. That's where we're based, and we're really talking to a Queensland audience. We'll flag the benefits of an occupational environmental physician and what they have to add and how they can enable an organisation, regardless of who the stakeholder is, in order to lead to a proactive framework that leads to hopefully shorter absences from work, appropriate rehab and return to work in a structured and safe environment, and a positive outcome for the worker and the employer, and hopefully the insurer, as well as the treating doc. I should say that for the OEPs here, the perspective is they're not treating. If you're treating, you're a patient advocate, is how it's seen, particularly with the medical legal framework, and the OEPs within this discussion and presentation, and certainly from my perspective, they may be treating, but in this situation, they're independent and able to talk to all stakeholders about the bias of being a treating doctor, so they understand where the treating health professionals are coming from. We'll reinforce the factor and the fact that good workplace culture is critical, as opposed to poor or no workplace culture. Well, that's pretty toxic. And you need a plan. The Army say failure to plan means you plan to fail. So if you haven't got a return to work plan, it's not much of an option. And unfortunately, that still happens. So for a few statistics, hopefully not kill you with lots of facts. In this here, you can see the numbers have actually decreased sort of as we're emerging. The data is from the financial year 21 to 22. The 22-23 data for Queensland from Safe Work Queensland is yet to be tabled and released. So basically you can see the number of claims is gone down slightly over the preceding 12 months. There's 63,000, so many from work cover, and the other 22% that's managed by self-insurers. That gives the other 27,000. You can see that site claims have increased slightly across it, the Queensland jurisdiction. The days to the site have slowly grown. The return to work rate has actually dropped. There's apparently some corrupt data in the 2021, 2022, if you read the Work Cover Queensland's annual report, and it's believed that the actual return to work rate is about 85 to 89%, which is a decrease. And I suspect some of it's due to COVID, but not all of it, and also changing social norms. And there's a few other pieces of data there we won't interrogate today. Just looking at the Work Cover Queensland data, which, as we said, makes up 63,000 and so many claims out of 90,000 for that year. Pardon me. You can see here musculoskeletal is very, very heavily still the leading cause and leading area for injury and illnesses. There's no surprises there. The other thing that's of interest, if you look at the 2021 and go to 2022, the incidence of mental health has increased. It's actually 14% for that year. And that I reflect is partly due to COVID, but also other societal changes. And the expectations are it will continue to increase. And of course, they're expensive. They're about 2 to 3 times the expense of a physical claim, and usually the duration is similar, at least 2 to 3 times. Excuse me. So for the Queensland data from 2022, over 90,000 claims, 86%, and these are stat claims. I should say that the common law claims are separate, and I haven't actually focused on them today because there's other drivers. I should say that for Queensland, it's about 3.5 to 4% of the stat claims actually are associated with a common law claim, and that seems to be a slight increase over the past few years. So you've got approximately 56% of all statutory claims for a physical injury don't require time off from work, and that's dropped a little bit over the past 10 years, but not by much. But obviously that means that just over 44% of all physical claims will require some time off from work. That could be a day, could be a week. Certainly if it's a physical claim that leads to a psych claim, that may be for a very prolonged period of time. So for the issue of return to work, so we're really talking about 44% of claims rather than 100%, but when an injury happens at work and leads to a claim, you can't assume. Some claims that are seemingly black and white quite often become rather complex and convoluted, as you'll see with the case study on presenting today, and we should apply the same rigour to all claims. The other thing to bear in mind is if you look at when a claim's intimated and put into an insurer, over 75% of them, over 3/4 of the claims are actually determined within 10 working days. This is for physical claims again. Psychiatric claims for the last financial year took anything up to 33 days for Queensland data to determine. And the challenge there, of course, is what's the diagnosis, which is much more apparent with a physical injury, whereas for a psych injury, it can be quite difficult to determine what the actual injury is. And then the decision has to be determined, is it pertaining to work, where work is a significant contributing factor reflecting the Queensland legislation, and that certainly can be a challenge. So for those reasons, the psych ones really don't apply within the 10 days. The other thing I thought that was of importance is if you look at within the 10 working day period, almost 7 out of 10 physical claims are closed. So you've got 10 and 7 of them are gone within 10 days. So, you know, sprain, strains, some lacerations, and such stuff, which form the bulk of these physical claims. So what we're looking at is basically you're looking at, well, particularly psych claims. As you said, that's somewhere in between 3 and 6% of all claims, depending on within the Queensland system for this period from 21 to 22. You've got 44% of them may require time away from work, as determined by the assessing doc, and you've got 30% of them, even if they require time away from work, will reach a point where they're closed within 10 working days. So we're not talking 90,000 claims, we're talking a much smaller number, but certainly it is still a significant percentage. So I just thought, just for some other data, if you look at the work cover return to work rates for the last financial year, they were aiming at 93. Unfortunately, they didn't get there, and their data is a little corrupted. So they know that it's less than that, and somewhere best guess is somewhere between 85 and 90, which is a significant drop from previous years. I should say for the self-insurers in Queensland, and this is in the Safe Work Australia annual report from 21 to 22, they quote 94.5% return to work rate success for self-insurers at 6 months post-injury. So there's a few challenges for all of us then. Excuse me. Sorry. Should say for the claim cost, you can see there's the average claim cost, and it's just over $11,000. And for psych claims, it's usually at least twice that or more, and there's common law as well. So and that's about 3 to 4% of all claims and slowly growing. So the trends going on the last few years, and particularly what has been noted over the last financial year, is that, and these are in no particular order, just one is claim costs are rising, statutory claims are taking longer. The average has gone from, if you average it across the system for scheme for Queensland, I think it's gone from 66 or something to almost 70, 71. So that's days away from work for all claims. So the total duration is rising, unfortunately. And the other thing is we're getting more mental health claims, and there's several drivers for that, but that's obviously a reflection of increased awareness. We've had some changes in our legislation, and also the definitions changed slightly, so that's given rise, and also there's increased public awareness, I would suspect. The incidence of secondary site claims has also increased, and that's about 3.5% of all physical claims, and it's slowly increasing too. But one can't assume if you've got a physical claim that you will get a site claim, but it does happen. And certainly if there's the evidence strongly supports, if you have a poor workplace culture, you don't have a terribly loyal workforce, there's poor lines of communication, and the return to work structure and practices within the organisation and across the organisation are poor, you're probably going to guarantee that your stat claim duration will go up, and so will your mental health claim as well. So there's no surprises there. Timely access to health professionals is an issue. COVID certainly has brought that to bear. I also think there's other drivers, and this is not just peculiar to Queensland or Australia, it's across the world actually. Ageing population, you've got younger generations want a better quality of life, and that may not be a bad thing, but it's certainly a challenge. And the issue of payroll tax, even, I think, as well, for Australia is an issue. So timely access is becoming a problem in an ageing population. So there's actually per head of capita, there's less, there are 1,000 people, there's less health professionals than what we had 5 years ago, unfortunately. So the other issue is less workers. I don't know where they've all gone, but particularly since COVID, a lot of employers, and it's all industries, struggling to retain their workforce and also attract other workers when they're looking at overseas. And certainly speaking to people internationally in various organisations, there's certainly a reduced scope to employ people, and they've had to take on employees or offer other incentives to retain current employees. So that's a challenge. The next issue is early intervention, and this is with proactive return to work strategies. And certainly Queensland and Australia has better practices, but there's still room for improvement. So as the health benefits of work and multiple other initiatives have shown, really from the time someone's injured, you've got to think about early intervention then, whether it's someone who's got multi-trauma from a motor vehicle collision as part of a journey claim, or whether it's someone who's sprained their ankle, because you can't guarantee they're going to be back in work in 2 weeks, and if they aren't, well then what structure and how do you communicate to the relevant stakeholders? So that's becoming much more important. And the fifth point that I believe is important in reflecting trends is certainly for mental health, the percentage is increasing, they're becoming longer in duration, and of course that leads to a poor outcome. And again, the issue seems to be for a certain group of injured workers, employees, there is suboptimal return to work strategies and initiatives developed, and that's for physical injuries. And I would say, and the literature does support this to some extent, that for people who have a mental health claim, be it a primary or a secondary, the return to work outcomes are worse, because I think a lot of the parties and the health professionals are certainly guilty of this, is they struggle with the treatment and returning them to work can become an issue. As an OEP, I would suggest that in an appropriate workplace, if it's safe work, then sometimes returning someone to work is a positive, not a negative for a mental health condition, but you've got to judge each case on its merits. There's a lot of facts. I just put that up there so it gives you some of you can read later, talking about the stat claims, their duration, how the mental health claims are now 10% of payments, but less than 6.5% of claims across the state, and that they've increased by 14.5%, and they take a lot longer to decide. And that's a reflection, as I mentioned earlier, of what's the diagnosis. Because someone who has a episode at work may be told they're depressed, but as I had an individual a few weeks ago, it was actually an acute psychotic reaction related to schizophrenia. So they had the psychotic episode at work, but that just happened to be a temporal association to work. It wasn't causally related. So, but that took like 3 months to determine that. So, as we said, they can be very challenging, not only in how to treat them, but to get the right diagnosis, and then for the jurisdictions to determine whether it's pertaining to work and a workplace injury. The facts, and I've tried to keep this pretty simple. I believe there's two factors that correlate and influence poor return to work. The first one is critical. It's the worker's ability to cope with their injury. And that doesn't matter whether it's a sprained ankle or whether they've had multi-trauma with 15 different injuries from their head down to their toe or anything in between. We all have different personal coping abilities, and a work injury or work illness certainly can stress people. As we know, there are other stakeholders. So you've got the insurer, you've got the employer, and you've got the worker, you've got the treating health professionals, and they all have expectations as well as perceptions. But the important part here is from the worker's perspective, if they don't believe that they can cope with their injury, well, that makes it very difficult to treat them and manage it in a health setting, but also means that the issues of return to work and progressing them to better health and using the workplace to enable that may not happen or becomes rather clunky. So that's really a huge opportunity for the various stakeholders to communicate. And certainly I think what's said by the treating doctors, particularly on the first assessment, particularly if they have a back injury and they reflect old-fashioned, out-of-date protocols, and particularly if they give them considerable time off and say they're disabled, that basically we're setting those people up for failure. And then you've got to try and retrofit them and try and convince them that what they were told initially isn't a reflection of where they are, and they do have capacity. So that's an ongoing issue, and unfortunately still happens. The other issue that's probably of equal importance is the lack of employee support, and I see that from two perspectives: either support for the employer as well as support by the employer. And certainly in a proactive, positive work culture, that usually is not an issue. Organisations that are proactive tend to use or know that return to work strategies is normal business almost. Not that they expect to have injuries every day, but they don't see it as exception. It's just part of doing business. Whereas for some other businesses, it seems to be that it's something for which they don't plan, and essentially their structures let them down, and they're doomed to failure. So therefore, it affects their employees. It means that basically their workforce tends to shrink. They tend to have a negative culture. Morale's low, and as we can imagine, they struggle. Also have increased premiums as well, because as we're all aware, your next year's premium for the workers' comp insurer to determine is based on history and using its previous 3 years. So really, for this, we need to communicate, we need to educate, and that's the appropriate stakeholders, particularly to ensure that the worker feels they're supported, not anxious and in fear. and will accept the fact that they have an injury. It will take a period of time, and they need help from multiple stakeholders to enable them to return to work. And that equally goes for employers where they need support, particularly if they feel marginalised or they're in an industry where they have very few injuries. But the other thing is for those that do have more frequent injuries and don't have a positive workplace culture or a business structure that embraces and accepts return to work as normal business, well, there's challenges there, and that's where we need to communicate and upskill. So, putting it in a more graphic form, these are basically literature search, and certainly reflects what the AFOM and the College of Physicians had structured as poor or suboptimal or no culture, encouraging a return to work. It's usually bottom up, so it comes from the workers or it comes from people outside. It's not at multiple levels. There's no buy-in within the organisation. There's invariably a culture of blame, so it's someone's fault. I thought workers' comp was a no-fault system and that we weren't dealing with damages and such stuff here today, but basically that doesn't, and certainly if it's a blame culture, that tends to lead to under-reporting, so people may report their injury weeks to months after the event, and that raises a whole heap of other issues, and particularly where they may have had suboptimal treatment or not accessed any treatment at all. There's the issue of is there an agreed return to work structure within a particular industry or organisation? Quite often there isn't. So it really becomes sort of very adversarial. So it's us against them. And that could even be your fellow workers, because they'll see sometimes someone who's had a legitimate injury, but they're not back at work, and what they think is a timely fashion, they see them as, less than a normal worker. People start to use the word malingering, which has strict legal definition. And unfortunately, people's perspective is their reality, but it's not always a reflection of the facts. So what happens is then with these organisations, these industries, the return to work's left to others because it's all too hard. They don't have any interest, they don't have any insight, and they don't wish to learn. So quite often they'll have one way of dealing with it, or they'll have no way of dealing with it, and everybody has to fit the same. So whether you've got a finger with a laceration, or whether you've got a back injury that needs surgery, or you've got multi-trauma from a motor vehicle collision, it's the same process for everybody. And it should be, but you've got to individualise and tailor it. So it's not just one fit for all. It's got to be tailored for the individual, and particularly if it's a cyclone or a physical claim with a secondary psych. As I quite often find, they don't have relationships with any of the health professionals nearby, be it the physios, the OTs, the psychologists, and particularly the local GPs and medical community. But what happens here is the worker sees their GP, who then becomes the default company doctor, quite often who has no insight or understanding in how the company policies and procedures work, and that's not the area of expertise. That's where the OEP comes in. But they're treating the health professional and not actually the company doc. But in this situation, quite often they sort of become the default company doctor, and therefore you get suitable duty programs that are developed sometimes in a vacuum. They aren't relevant or appropriate for that particular industry or that particular individual's return to work. And there's multiple reasons why that is, but ignorance is usually the most common cause. And of course, in these organisations, people, if there's a blame and bottom-up culture and it's us and them, there's low morale quite often. The culture at work is not great, and people are fearful of retaining their jobs and certainly don't wish to rock the boat, so they don't report. And if they do, it's usually at a time where things have become chronic and the outcomes may not be good. They tend to have a high number of claims for that type of industry, and of course, as we know, if you have more claims and you have a long duration, your premium goes up, so it's not rocket science. And essentially return to work is not a priority, which is unfortunate. So moving back to Jake. So Jake, he's the 23-year-old who works in a hotel as a kitchen hand a couple of years ago. There was a faulty PowerPoint in the kitchen. Some of his colleagues thought it'd be funny if they got him to use the faulty PowerPoint. Jake was unaware that PowerPoint was faulty, so they got him to plug something in. One day he got thrown back, so he didn't get electrocuted. He didn't lose consciousness. He didn't have entry and exit burns. He didn't have a cardiac arrest, but he got an electric shock, so it's still physical injury, and it was significant. So it threw him back several meters onto the floor. He got burns to his hands where he'd been hanging on to the plug, and superficial ones, thankfully. And he had soft tissue injuries to the upper limb. So that gave rise to a workers' comp claim. His physical injuries did heal. He thankfully didn't need surgery for his burns, but he needed a couple of weeks of burns management. 12 months after this event, he'd yet to return to work for a injury that really should have allowed him to return to work if not in the first week or two, but certainly by 3 to 5 weeks down the track. He now developed whole body pain. He was consumed with pain. He was mobilising only in a wheelchair. He'd seen multiple GPs, seen several medical specialists. He'd had quite extensive investigations, all at a cost to the system. They couldn't explain his pain, certainly not on the investigations, and therefore he'd been labelled as disabled and been told by various stakeholders he was a malingerer. So this is a prank that went horribly wrong, and that's when they didn't call for the Ghostbusters. They called for an OEP to help them out. So just to reflect a proactive workplace culture that's mature, you've got multiple levels, so it's really from management down. There's good lines of communication that's appropriate. They see return to work as part of normal business. If someone has an injury, it's got to be flagged, it's got to be thought of, and it gets factored in. That's the important thing. They provide training, insight and understanding, and they look for continuous improvement. So this is all about best practice. They have managers who lead the return to work process. They don't give it to the most junior supervisor or section hand on the floor or someone who's worked well and they just give them another duty. They actually have a process that has rigour. They also involve experts from outside who are knowledgeable. So they liaise with allied health professionals. They develop a relationship. They may have, and quite often they'll have a local GP or a clinic that may be the off-site primary care. You know, they're always seen as company doctors, but actually most of them aren't employees, they aren't contracted. They may manage the workers' comp. And if they're really proactive, they will invite those doctors in to actually look at the business, give them some insight and understanding so they can actually tailor, as well have done a worksite visit to let them know what's appropriate, suitable duties for various types of injuries, or whether, as is peculiar to workers' comp jurisdictions, the concept of host employment, which I think is woefully underused in multiple injuries. It tends to get thought of at the last moment rather than sort of with return to work. If we can't provide a formula at work to allow this person to return to work in safe and structured suitable duties, how else? And that's plan B. So it's all about failure to plan. So these organisations in industry tend to have low staff turnover. The morale is good. People feel secure. They're usually not anxious, maybe anxious, but not about their employer. They usually have a smaller number of claims and their premium because they proactive and manage them appropriately with the insurer and health professionals. Their premiums less, they're shorter duration, and they see return to work as normal business. So I just thought I'd ask you all a question. I haven't got lots of questions here, but this is one. It's straight out of the Health Benefits of Good Work. It's actually from 2010. So you've got a person, an employee, a claimant, a worker is off work for 20 days. What is 20 consecutive days? What is their chance of getting back to work? So there's 3 answers. Then you've got 45 days, chance of getting back to work. And then you've got 70 days. So you can have option A, B, or C. You can't cherry pick it. So it's either going to be 70, 50, and 35, up to 85, 75 and 60. So those of you who are across the health benefits of work, you know that the answer is A. So, 3 weeks, you're down to 70. A month and a half, you're down to 50. 70 days, 35. This is for physical injuries. Psych's actually worse. But I think the challenge for us then is to think about returning people with psychiatric claims to work in a proactive environment, but that's a discussion for another day. So, and then you go for those people who've been more than 6 months and say 8 to 9 months off work, the chance of getting them back to work is somewhere between the 8 and 12% mark. So it actually degrades as time goes on. So it doesn't take long. So the cost. So what surprises me is I've seen multiple managers and certainly employers who are actually ignorant of the true costs of ineffective return to work. They tell me, oh, we get someone in if it goes on beyond 3 months or something, which is, snowballs roll down the hill. You've got to think about it on day one, whether you actually implement it or not, another thing. So there's disruption to the employer. You've got staff turnover, you've got other staff having to catch up and work longer hours. You've got claims, you may have more claims, they tend to be of longer duration, and of course your premium might go up, so it does affect your bottom line, your profit. To the workplace, well, if people are injured and are aware they may get injured, well, that's not great for morale. It quite often affects production, so basically their product may not go out and therefore they make less money, and the workplace culture is poor. And certainly as an OEP, I've visited multiple workplaces in the last 25, 30 years. I reckon within 5 to 10 minutes of where you visit someone, regardless of who they are, you get a fair idea and feel about whether this organisation actually walks the walk or just talks the talk. And when OEPs have the luxury of visiting work sites and interfacing with various levels of management and workers, but certainly, from the front door, even before sometimes you meet the seniors, you've got a fair idea that basically, there's issues here and you haven't even gone to the factory or the floor. So, and sometimes I've had 1 or 2 places you could almost cut the atmosphere with a knife, just very, very difficult. I mean, who would want to get up and go to work in an organisation like that? Some people do. So, and then you've got the individual, the worker, the employer. So they may be off for a prolonged period. The longer they're off, the more deconditioned. The other thing is for Australians particularly, if you're not at work, quite often you're disenfranchised from your social network, your social interaction. They become isolated. People don't visit them. They don't want to interact. They want to know them, and it all goes pear-shaped, and quite often leads to no return to work or several return to works which fail. So that's most unfortunate. The other thing is there's quite a bit of evidence, particularly from America, and ACC New Zealand have done this as well, is the impact of one phone call or one card or correspondence from an employer that's positive. So we're not talking an email or a correspondence that says, where's your workers' comp certificate, or why haven't you returned to work? Because sometimes that's the only correspondence they get. This is one where they'll say, realise you're injured, wish you well in your recovery, and there's anything we can do for you. So or just wishing you a speedy recovery. As opposed to some organisations that actually get and organise people to go out and mow their lawn and do other things. So I'm not suggesting that, but basically just from the perspective of a positive contact, a phone call 2 or 3 days later when they're in hospital, as opposed to sending a card to someone who's in hospital. The impact on return to work compared to none of that is in the vicinity of 35 to 40%. So basically, you don't have to be smart. You've basically got to be situationally aware and basically show that you care, or at least that you're thinking of someone. So, and good and proactive organisations already know this and are across it. So, getting back to another stakeholder, the general doctor. Yes, this is most usually a GP, or it could be ED, emergency medicine doctors. public and private. You've got to bear in mind that doctors are health professionals who, in the main, are good at their skill, which is the medical aspects of assessing, diagnosing, and then treating. They do not visit workplaces. They do not usually go into great discussion about your role and responsibilities. And they don't talk about suitable options in great detail because they're dealing with a patient. It's not a worker to them. It's not an employee. It's their patient. They may have seen that person for the first time on that day, and they're not a long-term patient, or it could be someone who they've helped deliver X years ago, or the third generation involved with that particular clinic. So there's usually a relationship that may have been long-term. And the thing is, it's not focused on work, it's focused on health. And I think for the employer and definitely for the insurer, they struggle with that because they see that the workers' comp system is terribly important, and it is. But I think the thing is, you have to bear in mind, and this is with the if you look at the workforce data for health in Australia over the last 20 years, the number of consultations for the average GP in an average week, I don't know how much COVID impacted upon this, is less than 2%. It's about 1.85%. So out of 100 people in a week, the average GP would see less than 2. Yes, there are some doctors who, by virtue of interest or location or geography or demographics, they see a lot more. And there's other GPs and other professionals who basically, for negative reasons, decline to treat anyone in the workers' comp system. And so it's not a perfect world, but you've got to bear in mind the doctor is there for health issues. Workers' comp is not big in their world. And when you compare it to a certificate that's a medical certificate for sickness, you know, for every workers' comp certificate that's written out in Queensland, there's probably 45 of the other ones written out. So the thing is, where it's not an equal playing field. The other thing on these certificates is they're generic. They don't have to say what the condition is. And certainly under the Privacy Act, a medical condition or a surgical condition is pretty much what most of them write. Some might write happen at work. Sometimes it reflects the facts, sometimes it doesn't. But the focus is on inability to work, not capacity or ability to work. So it's a totally different mindset. There's been a lot of upskilling and a lot of work put in by the faculty of OcMed, as well as the College of Physicians and the College of GPs and the workers' comp jurisdictions around Australia and New Zealand on the health benefits of work. But I still run into GPs that are unaware that, well, unaware of AFOM, unaware of the existence of OcMed as a specialty, and certainly unaware of the health benefits of good work. So there's a few challenges there for all of us. An important point that other stakeholders forget is that, particularly if it's a long-term patient and the treating doc or doctors are seeing them for a workplace injury or illness, they're a patient advocate. So therefore their role and their independence is focused on their patient. It's not focused on the insurer. It's not focused on the employer. I would state it's not focused on the worker. It's about the patient. And sometimes what the patient tells them about work may be a reflection of the facts, and sometimes it's not. So therefore, it's about the doctor-patient relationship, and it's about therapy, and it's about outcome. It's not about work, and that's a challenge. So how do we work around this? And this again is where people such as occupational and environmental physicians can straddle this as an independent assessor and an independent medical specialist. They're aware of, well, I would hope so, the health benefits of good work, treating doctor role as opposed to an independent role, and how do you access various health professionals within the health system and improve communication and reflect what options there are and how to lead people forwards. So it can be complex, and the thing is, at the end of the day, I believe you've got to have, particularly if you have certain number of GPs in your local area who have some interest in workers' compensation, but you haven't invited them into your factory, you haven't had dialogue with them, I think there's lots of opportunity. And for those who aren't interested, well, you know, a challenge is an opportunity, as Confucius says. So I believe you can always try and engage. The general practitioner's role, as I said, it's not workers focused, not in any way, shape or form. It's the exception rather than the rule. Cohen and his cohorts in several studies reinforce this. It's usually classic therapeutic doctor-patient relationship. They do not see themselves as articulating or discussing it with any other parties. I think the challenge here is if the fee is paid for within a workers' comp jurisdiction, then basically the treating health professionals have to deal with that jurisdiction, and that includes the insurer and the employer. So, challenge to get everyone in the same hip shape. They are advocates for their patient. That is not from a work perspective. And certainly in the past few years, with decreasing health workforce issues and COVID, there's pressure on consultation time. People have concerns as patients, and workers' comp and work injuries is not high on the agenda. And as I mentioned before, for most health professionals, and that's where the OEPs are unique here, most health professionals have either no or very limited occupational health expertise. You know, maybe their only health experience, or when they last visited a factory, is when they were a med student or before they did medicine. So maybe decades old and not relevant. And certainly I ask a few doctors who don't work in this space, or do but don't understand the system, and simple things like rehab and return to work coordinator, they just have no insider understanding. So that's not a criticism, it's just a challenge of how we need to inform, communicate and upskill various stakeholders. And if we don't, well, it's just maintenance of the same. I'd also like to reflect that the workers' compensation medical certificate, and this is reflected around Australia, but since we've got a Queensland presentation, and I was partly involved in this certificate's evolution, so it's not my baby, but still, it's a capacity certificate. It's not an incapacity certificate like the certificates were 25 years ago. So if you look at the areas I've highlighted, it talks about rehab and return to work and what you can do, and it talks about suitable duties. So it's actually flagged there, and the health benefits of work is mentioned. And the other thing is we go from capacity up here, functional capacity, down to incapacity, whereas the old certificates were flagged the other way. I think there's actually some health professionals don't realise that, but there is a subliminal message there. So it's about what capacity do they have and how can we enable it, given that returning someone to work, even for a couple of hours a day, several days a week, is a proactive stance, and will certainly augur well, hopefully, in that person's return to wellness and back to working normal hours and normal days. So, and then you've got options. So for all of us who are frequent flyers, we're aware of this. So then you'll say, well, okay, I rabbited on and talked about the occupational environmental physician. As I said, they're medical specialists. They're registered under APRA. We deal with the issues, illnesses and injuries pertaining to work or that impact upon work. So it's quite a broad area. Some are employed by business, some work for government, not very many, I think, and certainly not for many health departments, because they think other doctors can measure, can deal with their workplace issues, but they sometimes learn the hard way. So we can be treating, but for the main, and certainly from my perspective, I spend more time as an independent rather than treating, but I think it's good to have a treating side. But for when we're involved in these situations with insurers, employers and workers, you need to be independent, you need to be appropriate, you need to be a good communicator, and you use your medical skills as a specialist to maintain people's health. And that means you have to be able to have dialogue, communicate, connect with not only just the workplace, but you've got to communicate with various health practitioners or services. You've got to communicate with the insurer, and dare I say it, the worker and sometimes their family. And this is all about trying to explore options to increase their health and enable them to return to work and remain well. It can be a challenge. So as I said here, we work with multiple stakeholders. And unfortunately, sometimes the most challenging people are our peers, but we all like challenges. So in no particular order, we tend to communicate with all stakeholders. There's various jurisdictions talk about the 3 C's. I think the 3 C's are communicate, communicate, and communicate. And if you haven't done it enough, then you add communication again, so you can't communicate too much, particularly with people that need to be upskilled. We have the luxury as OEPs, we can visit the workplace. We can actually see where the person works. We can, and if not them, then someone else, by day or by night. And the thing is, it gives you insight and understanding. It gives you credibility. And the other thing is, you deal with management. You know, you talk to the leading hands, you talk to the supervisors, you talk to the managers. And for those who've been around a while, sort of have a fair idea of what's appropriate and what's not. And then it's practical application of the health benefits of good work. And how do you tailor that for a return to work model for that individual? Because it's not one model fits all. You've got to personalize it and make sure it's appropriate. So the other issue where we have great skill, and this is part of our training, and we're the only medical specialist taught risk, relative risk, factual risk, but we talk about risk and we understand risk matrix and how to apply them, and then basically in order to minimize further issues on a return to work. And the thing is, it's not symptom based, because people can have, you know, an injury or an illness where the symptoms have settled, but they've got underlying pathology which won't take much to flare up sometimes. So it's really about managing the whole person, not just the particular piece of anatomy that may have been injured or ill, because sometimes they have other issues as well. The critical factor here is not only do we understand medical aspects of injury from a health perspective, but we also understand them from a non-medical and, dare I say it, occupational perspective, which is extremely important and relevant for people who don't have injuries and illnesses pertaining to work. And as I flagged before, you know, quite often we're independent. If I've treated someone in the past, well, obviously I can't be independent, so it needs to see someone else. But basically understand the treating role, the positives and negative aspects of that, and where there's boundaries, and basically how you can work with treating health professionals in a proactive way and get them on side and hopefully enable them to understand and want to be involved in the future. That's the challenge. So you give them a positive experience rather than a negative experience with a good outcome, hopefully, for not only the worker, but also other stakeholders. So I put this in a tabulated format. The best approach, and the literature certainly reflects this, is stay at work. That can be extremely challenging in some cases, depending upon the spectrum of injuries and illnesses. You've got to give them a return to work that's meaningful, and sometimes they're not. So therefore, you know, the return to work doesn't work. So it's got to be meaningful and appropriate. So it's got to be tailored. One can't be generic. You've got to communicate, as I mentioned before, and you've got to have restrictions that are appropriate. They've got to be followed. No point in writing a prescription for return to work as a recommendation. It's implemented, but no one follows it. And then it's got to be progressive. So it's got to be a graduated step process. And I'll sort of put that into a tabulated format on that slide. The benefits we've spoken about before: early return to work does reduce disability. You need early intervention, as I said, really from day one. You need early appropriate treatment. And that may not be a lot of health professionals, but it may be the fact you need restrictions and early return to work as appropriate. And as we know, if you have injured workers who are offered suitable duties, the evidence shows they're twice as likely more to return to work. And as the evidence shows on the converse, if they're duration of claim is long, their chances of returning, and particularly if it's 8 to 12 months, you're looking at the vicinity of like 8 to 12% success. So there's lots of positives for an OEP, enabling and working with a proactive workplace, and I've just put that in a format that we've discussed before. So getting back to Jake. So Jake's basically was 12 months down the track. His physical injuries had healed. He had inability to walk, chronic pain, whole body weakness. He was sent to me as a file review because the employer and the insurer just wanted to know, well, where to from here? Been told he's disabled and never work again. So the issues, and I actually did a worksite visit here, was it was really inappropriate and poor workplace culture. Jake was, and I actually got to see Jake. Jake was mobile in a wheelchair and he was severely depressed, which no one seemed to have identified from a health perspective. His treating doctors, including his medical specialists and allied health professionals, are focused upon the fact he had high pain levels and how medication and injections were going to help this, and multiple medical certificates which seem to reflect with each other on a monthly basis. He told me, and other people told me he's disabled and he'd never work again. So it wasn't a very happy situation. So what do I do for this? I put on my hat as an OEP and I want to access all the medical records. Then you've got to read them. Then you've got to work out what's important. And is there something in there that's critical that's been missed? You then need to communicate with the stakeholders. You then got to put all these pieces together so it makes sense, and then ultimately you make recommendations. I'm not God. I might be good, but I'm not God. And at the end of the day, I can't dictate. I can only make recommendations, and it's up to other parties. So I did a worksite visit that told me about the culture or the lack of it. I had discussions and visited Jake. His mother was there. She told me he was disabled and never work again. The treating docs, I had a phone call and one doctor was very appropriate. He told me he knew all about disability. So really you got this. So my assessment was that he had major depression. There was 2 lines in the 900 plus pages that I read. So I saw him about 14 months after the original injury, where the GP's notes had mentioned that he had significant childhood abuse as a young child, and this actually was where it came back and resurfaced. So I asked for him to be referred to an independent psychiatrist who concurred with me. He was depressed, wasn't disabled, and he needed extensive psychotherapy from a treating psychiatrist and psychologist. That actually made great inroads to his chronic depression. And the problem here was his pain was real to him and other people, but the pain was a symptom of other problems, and people were treating the symptom, not treating the person. So really it was a somatoform disorder where people have lots of pain, but sometimes the pain's not the issue, it's something else. And it led to kinesiophobia, so he wasn't moving. So basically, so at the end of the day, we divorced him from all his mobility aids. This is not Jack, but someone like him. He actually did, over a period of 10 months, get back to being mobile. He returned to paid work, same employer, different location, another hotel in a similar role, and he's work capable. So he's gone from being disabled, as he was told by multiple people, unfortunately, including health professionals, to now where he's work capable. So from a perspective as an OEP, we identified the risk, we managed the risk. He should have had early intervention. It was bleedingly obvious at the early phase, but unfortunately that was lost on multiple stakeholders, the employer, the insurer, and definitely the treating health professionals and the family. And what do I think for this? If they send him to an aware and appropriately trained medical specialist, such as an occupational environmental physician, at 2 months or even 1 month, I think this would have led, I believe this would have led to a much more proactive and earlier return to work and a better outcome. Unfortunately for Jake, he lost almost 2 years of his life. He raised the premium for that company and he can't get back the time he's lost. But he's back at work and he's capable, so that's a good outcome. So there's the references, and if there's any questions, I'm happy to answer them. So I think I'm pretty much out of time now. So If there's no questions, I just want to thank you for your time. I hope this was of benefit and gave you some insight and understanding with a few current references for what reflects best practice, particularly to return injured and ill workers back to work. So thank you for your time. Enjoy the rest of your day. And if you do have any questions later, you can always email me and I'm happy to answer. Thank you and safe travels.